Presentation is going to be from Professor Andrew Udi on invasive neuromonitoring for severe traumatic brain injury in the ICU, which is a very, very interesting topic for us, especially in the moderate severe traumatic brain injury space. I'd like to first just acknowledge the owners on the land, the traditional owners on the land on which we meet today. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and we recognise their valuable contributions to Australian and global society. So, as I said, we're privileged to have Professor Andrew Udi today. He's the head of research at the Alfred Intensive Care Unit at Melbourne in Victoria, and is the Deputy Director, Australian and New Zealand Intensive Care Research Centre at Monash University. So he wears a couple of hats, which are quite prominent in the traumatic brain injury space in Australia. His research interests include sepsis, traumatic brain injury, neurocritical care, and extracorporeal membrane oxygenation. He's obviously passionate about supporting trainees and early career clinician scientists and increasing diversity in clinical research. He's also the Vice Chair of the Australian New Zealand Intensive Care Society, so ANZICS, if you've heard of it, which is a clinical trials group, CTG, and is proud product of Aotearoa New Zealand. So we welcome you today, Andrew. I think this is a very topical area for everybody to learn about. And I think there's not much being done in the intervention space as much as we can for patients with traumatic brain injury or severe traumatic brain injury. So we appreciate your time. I'll just stop sharing my screen and allow you to share your slides. Thank you so much again.
Thanks, Fatima. Thank you for the really kind introduction and for the invitation to talk to the QBIC group today. As we were chatting about before, I spent quite a bit of time in Queensland. I worked at RBWH as a clinician, did my training there, so very much the second home for me. So it's a real privilege to talk to the group and to talk about, I guess, a little bit around some of the clinical controversies and questions we have around the best care or the best evidence-based care for traumatic brain injury in the intensive care unit and some of the different research topics and research themes that we're exploring. So as already mentioned, I work at the Alfred, also at Monash University as part of the ANZIC brain injury program. Just to note in a disclosure, I have received some in-kind support for a large randomized controlled trial from Integra Life Sciences Incorporated. They make neuromonitoring equipment, and it's been unrestricted from the point of view that they don't have any say in the research that we undertake or the outcomes from that, but they have kindly provided that support. All right, so we'll just hook straight into it. I think one of the things which has immediately challenged us in intensive care and more globally in the clinical traumatic brain injury community is the new definition for TBI. And this is something that I think that we need to start now embracing within Australia and in New Zealand. And we need to start incorporating into our clinical trial protocols and clinical research endeavour. So this was the publication from, which was in the Lancet Neurology, which talks about the CBIM nomenclature for traumatic brain injury. I'm sure you all would have seen that. But I think this is going to impact us, and it's particularly around the use of common biomarkers. Now, there'll be a significant number of people on this call which have a lot more experience with biomarkers than I do. But as a clinician, we've been searching for quantifiable metrics of neuronal injury for quite some time. We typically would use a clinical scale like the Glasgow Coma scale, and then CT imaging or other imaging to define the amount of structural injury. But obviously that's pretty coarse. Certainly clinical evaluation can be confounded by illicit substance abuse, other sort of extracranial injuries, sedatives, analgesics, etc. And again, CT imaging, although very widely available and within Australia, is only going to give you a sort of a macroscopic view of the brain injury. And so the introduction of things like GFAP or UCHL1 and S100 beta have been, I think will be a game changer when we talk about brain injury, and particularly perhaps more so in patients with supposed mild injury who present to hospital with only a very minor reduction in their GCS. But then go on to have quite an elevated biomarker levels. That has significant prognostic implications. And this was, something that was identified by Track TBI. This is one of the studies that has been published over the last sort of decade or so looking at the value of these biomarkers. So this is just GFAP and UCHL1 out of the US platform. Patients presenting to an emergency department with a traumatic brain injury, they will have bloods taken on the same day as imaging. And then they looked at the value of GFAP in particular in terms of its looking at its ability to discriminate survivors from non-survivors and those with a favourable versus an unfavourable outcome. Looking at the GOSE there, you can see that obviously those that died and had a more unfavourable outcome had much higher GFAP concentrations, and importantly, even in some patients which presented with a Glasgow Coma Scale score of 13 to 15, which was actually the vast majority of those patients, some of those patients died and they actually had quite high GFAP concentrations. So I think it tells you that the biomarker concentrations within the clinical setting can add value. They can help you to discriminate between those patients which are going to do worse, and this has really important implications for the care you're going to provide, the level of observation, perhaps the amount or the degree of neuromonitoring. But more importantly, it can help to inform patients and family about the actual extent of the brain injury and the likelihood of a good functional outcome and potentially supports that might be needed in the future. So biomarkers are here, they're coming. There's been some initial work out in Western Australia led by Rob McNamara, who's doing some work on that in the intensive care setting. Dev Mitra here at the Alfred is doing some work in ED, and we're just about to complete a prospective study of looking at GFAP and UCHL1 levels in our cohort of patients to understand the kinetics of these biomarkers better and how they can help to inform clinical practice and clinical decision making. I suppose the next thing is that, what we're trying to move towards is this sort of, I guess, idealistic, aspirational environment where we have all this data that is sort of being provided to us real time, that we can integrate, both biomarker data, clinical data, electrophysiological data, neuromonitoring data, all within a platform that allows us to make more better informed clinical decisions, and that can really provide the best environment for neuronal repair and recovery, because primarily the injury with traumatic brain injury happens, of course, at the time, as everybody knows, where there's force applied to neurons, which leads to disruption and death of tissue. But obviously secondary injury then can propagate that over a number of days to weeks to even longer. And in intensive care, it's all about trying to provide the best environment to prevent that and to allow recovery to happen. And we know that I'll just, this is really just to beat my own drum a little bit, which is that from the point of view, we do know when we've done a systematic review of the literature that certainly putting patients or caring for patients in specialized environments where there is access to advanced neuromonitoring and specialized staff is associated with improved outcomes. This is just some systematic review from JAMA Neurology performed by Zhizhan Fan, who's a PhD student, looking at the value of admitting patients to these centres and the association between admission to one of those sites and improved functional outcomes, which she demonstrated. There's roughly a 17% improvement in functional outcome and reduction in mortality or improvement in survival. But the reason for that is a bit unclear. Is it because of the staff that are present? Is it because of allied health interventions? Is it because of checklists or protocols? Is it because of just simply cohorting the patients together? Or is it because of the neuromonitoring and other processes that are available? And that's part of, I think, what we have to try and tease out with future research is which of these components are actually the most important, and how can we resource them better to improve patient-centered outcomes? Or maybe it's just a whole bundle of care, in fact, actually, and we need to look at perhaps at process interventions and process of care, things that we can do better right now today to improve the outcomes for patients with traumatic brain injury. But I think that while my talk is going to go on to talk a little bit about enhanced invasive neuromonitoring and also the use of other technologies, it does come down to the fact that we need people at the bedside looking after these patients, being well educated and applying evidence-based care to get the best outcomes for patients with TBI. This is the first thing I want to talk a little bit about is the current clinical guidelines for traumatic brain injury, particularly around perfusion. So these are the Brain Trauma Foundation guidelines, which are really sort of the Bible when it comes to clinical management of TBI. You'll see there's a number of stipulations. What I want to talk about is the blood pressure thresholds or perfusion thresholds. One thing that was which is, I guess, critical to clinical management of traumatic brain injury is the maintenance of adequate perfusion to the recovering brain. We don't want to make the brain injury worse by causing a reduction in perfusion, reduction in delivery of oxygen and glucose and other nutrients to those cells. The exact blood pressure target has always been a little bit unclear. It's been up for debate, but the Brain Trauma Foundation guidelines have recommended this idea that you need to maintain a cerebral perfusion pressure, which is the difference between the mean arterial pressure or the patient's blood pressure and their intracranial pressure, the pressure within the brain. And that CPP target should be somewhere between 60 to 70 millimeters of mercury. Down here, it's a level 2B recommendation. And you need to avoid episodes of hypotension. But, that's pretty broad. It's quite a significant range, to 10 millimeter mercury range. A lot of patients can have a CPP below that or above that. And how does it really, how is that sort of this number, how is that informed, and can we do better in terms of actually identifying individual perfusion targets? And the answer to that is that we can, because this is, we know that patients have a broad range of traumatic brain injury. They can have focal injury, contusion or hematoma, more diffuse injury. There can be diffuse swelling. There can be subdural hematomas, extradural hematomas, subarachnoid hemorrhage. And not only is the injury, there's a huge amount of heterogeneity, there's a huge amount of heterogeneity in the host, the age, gender, their baseline physiological parameters, blood pressure, any comorbidity they might have. They may have extracranial injury, which may lead to additional illness severity. They may have been delayed in terms of their presentation to hospital. They may have already received other treatments. So this single, blood pressure target of 67 CPP of 60 to 70 millimeters of mercury seems a little counterintuitive in many ways to a clinician, where we spend a lot of time thinking about the individual patient in front of us and how can we optimize the care that they are receiving. And so there has been some work on this, trying to think about, is there any way that we can optimize perfusion if we understand a little bit more about the patient's cerebrovascular status. And there's this idea of cerebral autoregulation, which again, many of you would no doubt be very familiar with, which is a very highly conserved physiological response to changes in blood pressure perfusion to the brain and health, which means that regardless of a range of perfusion pressures, blood flow is maintained at cerebral blood flow is maintained at a relatively static level. And this is because the brain is the most vital organ. And as a consequence, there's been a number of physiological mechanisms that have been preserved over many thousands of years in order to ensure that blood flow is constant so that neurons survive. And this idea of cerebral autoregulation is well taught, well established within the different textbooks. You have the classic Lassen curve here, which I'm demonstrating on the slide, whereby that as you're between the sort of lower limit of autoregulation and upper limit of autoregulation, cerebral blood flow tends to be maintained. The thing is with severe traumatic brain injury is that, of course, the patient's individual Lassen curve will vary. Their relatively stable perfusion pressures are going to be different, and that's going to depend upon the nature of their injury, their age, their comorbidities, their previous blood pressure, etc. And there now is a way of being able to calculate or determine what is the stable perfusion pressure for an individual patient using continuous real-time high-frequency neuromonitoring. And this is using some technology which was developed by the Brain Physics Lab in Cambridge University. This ICM Plus is a software package which you can apply. You put it on a laptop. The laptop is connected to the patient's bedside monitor, and it continuously streams information about that patient's physiology. And we can map changes in pressure to particularly the intracranial pressure to changes in the CPP. And in circumstances here where the patient's pressure measured within their brain is well correlated with the patient's arterial blood pressure, that means that the correlation coefficient here is a positive number, and it's very closely approximated. So the PRX which is the term used to refer to this correlation coefficient, is positive, and it's a high number. As the relationship between ICP and blood pressure begins to become less correlated, and so the PRX, the correlation coefficient, decreases and it can even become negative, that means that there is less of a correlation. So There isn't, for a change in blood pressure, there is not a correlating change in ICP. And it's that situation where autoregulation is intact. So we have a change in blood pressure, but there is no change in ICP. And the reason for that is that your cerebral autoregulatory mechanisms are intact. And that is a good place to be. That is where you want to be from a traumatic brain injury perspective, in terms of it means that your regular or normal sort of neurohormonal and physiological mechanisms are working. So this is where we want to be. We want this PRX number to be very low. Now we can measure this by using high frequency data. We can make this correlation over time, and you can then plot this U-shaped curve and at the points where the PRX, or the correlation coefficient, is less than 0.1, so sometimes less than 0.2, depending upon the papers you read. But between these 2 points here, this green arc, that is your stable perfusion pressure, your stable cerebral perfusion pressure, or sometimes referred to as the optimal perfusion pressure, or CPP opt. And so that gives us a real-time, usable indicator of what is the best perfusion pressure for that patient at that time. And when you think about it from a clinical point of view, that is that's amazing, right? Because we've now got something where we can base therapy directly on the patient's physiology, and we can then trend it over time. We can change our management strategy, etc., rather than just applying a uniform sort of range of 60 to 70 millimeters of mercury to every patient at every moment. And these are the sort of, some of the things that I've already just mentioned. So this is this idea of CPP opt. And if you certainly go to the literature and you look at the sort of latest developments within clinical management of traumatic brain injury, optimal cerebral perfusion pressure, or optimal perfusion, is really gaining some traction. And there has been quite a large amount of observational data. I'm not going to go through it here, but the pressure reactivity index, this correlation coefficient, is a measure of cerebral autoregulation, and its application to TBI management is most of these data come from the Cambridge team and the brain physics lab. But there's a wealth of observational data which suggests that the further the deviation in terms of the patient's perfusion pressure from CPP opt, the worse they do. So that's an observational component. So we know that basically if you just choose a random range of perfusion pressures and you do not titrate your therapy to achieve this, the patients will do worse. But it's observational data. It's clearly a selection bias. There's clearly a variety of different things that could confound that assessment. Single center largely. So we have to just be careful with that. But there is quite a significant amount of data now, which is over the last decade, and moderate-sized cohorts in terms of this patient group. But what's been very interesting was the Cogitate trial, which was published some time ago now, which actually randomized patients to either this individualized perfusion pressure strategy, where you measure CPP opt and you titrate your care to CPP opt, or you just use standard wild type management in the intensive care. It was a proof of concept study. It was only a very small number of patients. So they only randomized 64 patients. There's only 32 in each group. The one group were allocated to the CPP control group. So that's just standard treatment parameters and looking for 60 to 70 millimeters of mercury, versus the other group, which had the CPP intervention, where they put the laptop on the patient, they measured these data, they collected the CPP opt value, and then they titrated care to achieve that CPP opt number. Now, in certain circumstances, you can't always calculate a CPP opt. It's a mathematical construct. Sometimes the data don't quite work. In other circumstances, it spits out a number which is just biologically implausible. So sometimes you don't apply that. But they went through this, and they then collected information about the blood pressure achieved, what was done in the intensive care unit, and more importantly, what the patient was like when they were discharged from the ICU. And this is just a little bit of a table or figure which demonstrates what they did, and how often they had to select a particular blood pressure target. This is the therapeutic intensity level, so how these patients were managed over the sort of first 5 days in the ICU. And you can see here that the TIL was very similar. So it's not like the intervention group got a whole lot of extra therapy. They just got more precise therapy and more sort of directed therapy. And then this was the primary outcome, which was the percentage of time where the CPP, the actual measured perfusion pressure, was concordant with the target. And they managed to do that in 46.5% of occasions or of time. And then there was a variety of safety metrics, etc. But what was very striking here was the difference in clinical outcomes. Now, this is a very small study, and we have to be very careful, I think, about it. But this is at the Glasgow outcome scale in patients that were allocated to the control group versus the intervention group. And you can see here, when you look at the patients that are deceased, those with severe disability, good recovery, moderate disability, etc., you can see that there is, at least visually, there appears to be a signal towards improved clinical outcomes in patients that were assigned a strategy whereby perfusion to the brain following traumatic brain injury was optimized and was tailored to that patient's physiology in real time. So this is probably one of the more exciting components in terms of managing patients within the ICU with traumatic brain injury. The difficulty is that it is technology that is often quite foreign to the average clinician, and you have to believe the mathematics, and you have to be confident that the laptop is giving you information that is reasonable for that patient. But certainly this was a robust trial out of the UK, and there was another centre in the Netherlands, and this has certainly given us pause for thought about whether we should start implementing this sort of intervention more widely in the clinical space. And it's certainly something to watch. Indeed, some current guidelines have started to introduce this. This was the CBIC guidelines from some years ago now, which included, I think, people like sort of David Menon from Cambridge and other key opinion leaders within the clinical traumatic brain injury community. And they've introduced this idea of a MAP challenge, which is really a bit of a poor man's CPP-opt, is where you actually just drive the blood pressure up clinically. You can do that with medications or fluid therapy, and you see how the patient responds in terms of their intracranial pressure. And if it comes down, then that would suggest that you've got room to increase the perfusion pressure and continue with that. But so it's starting to make this idea of assessing the patient's autoregulatory status, either using the laptop and a whole lot of very fancy maths, or simply even just giving the patient some more blood pressure and seeing how they respond, is starting to make its way into routine clinical practice. Yeah, we've done a little study here in Alfred as well. We did the same. We did very well. We sort of did this, and we escalated the patient's blood pressure and looked at the response in terms of intracranial pressure. And indeed, it does what it said. It does what it said it would do on the box. If you give patients more blood pressure and their autoregulatory status is intact, the intracranial pressure falls, and that's an important sort of or useful physiological outcome. Whether or not that this translates into patient-centered outcomes at scale is who knows, but it's certainly something that we've looked into. So that leads me to talk a little bit about ICP, and we can come back and talk about perfusion pressure, CPP, a bit later if you like in the Q&A. But intracranial pressure is the other main thing that we really focus on, which in intensive care is trying to reduce the burden of intracranial pressure and to try and and this is part of it, is to maintain perfusion to the recovering brain, as I've said. But it's very interesting when you go back and look at the data around ICP, and I think we need to reframe our thoughts and our considerations around intracranial pressure, because there's actually quite a bit of data to suggest that the way we're doing it at the moment is in fact actually not all that helpful. This is the only study, a very large randomized controlled trial. I should say it's the only randomized controlled trial. There have been other studies, but this is the only RCT which was published over a decade ago, which looked at intracranial pressure monitoring as an intervention in patients with severe traumatic brain injury, undertaken in Bolivia and Ecuador. Patients were randomized to either get the monitoring inserted via sort of cranial surgery, or they had just had repeated neurological examination and imaging. And this actually demonstrated no difference in outcomes. So, it was it's really a defining clinical trial from the point of view that it suggests that perhaps ICP monitoring isn't needed if you look strictly at a randomized controlled trial data. But on the other hand, there are a lot of questions about the validity of the trial findings from the setting. So it was in Middle America, doesn't necessarily represent what we do here in Australia. The control, I suppose, population, those that did not get a monitor but still got neurological assessment and CT imaging, there was still an awareness around ICP, and there was still treatment of ICP provided. It was just based on clinical findings and radiological findings. So it's not like that intracranial pressure as a construct, was completely dismissed here. It was just simply the way that it was assessed, and which was the topic of this trial. This has not translated into clinical practice. You will, if you go to any major neurotrauma centre in Australia, you will find patients with ICP monitoring. Yeah, and similarly in the United Kingdom and the USA, Canada, most high-income countries would routinely use intracranial pressure monitoring in patients with moderate to severe traumatic brain injury. But it is interesting. The only RCT we have so far suggests that it wasn't of benefit. The trouble is that there are a few other studies that suggest that it may in fact actually be associated with harm. This was a large observational study, which was a comparative effectiveness study published in JAMA Network Open from quite a significant number of patients, about 1,500 from 43 intensive care units, that compared those that got ICP monitoring with those that didn't. And it suggested that those that that underwent ICP monitoring had a worse outcome. And so this is obviously observational. Again, it doesn't take into account perhaps of some of the illness severity characteristics of the patients. And there's not enough granularity here to understand how the data were used and what sort of interventions were provided as a consequence. But this has certainly generated some debate within the clinical TBI community as to what is the most appropriate form of monitoring, because there is this sort of ongoing debate about the value of ICP monitoring. And there's also been a number of studies which have tried to look at interventions to reduce intracranial pressure. This was the Eurotherm 3235 study again, about a decade ago, looking at hypothermia. Here, hypothermia as an intervention significantly reduced ICP, but was associated with worse functional outcomes. So as a rescue intervention, hypothermia didn't work. This was the DECRA trial, which is the ultimate intervention to reduce intracranial pressure. So here, patients are randomized to have a wide bifrontal decompression where their skull, the front of their skull was removed in order to allow the brain to swell if need be and reduce ICP. And you can see here the standard care arm had ICPs around 20, which is a typical threshold, versus those that had the intervention and surgery, the ICPs fell to below 15. But in fact, actually, those that had decompressive craniectomy did worse. They had worse functional outcomes. More of them were disabled. So even though you had better ICP control, patients had worse outcomes. And this probably relates to the fact that the intervention, in fact, actually led to harm because of the swelling and the stretch of neurons is being proposed, that in fact, actually a little bit of intracranial pressure, in fact, actually may be beneficial in terms of preventing the influx of water and worsening edema. And then when you relieve that pressure, it's a bit like opening the can of a can of Coke, and you get this massive sort of welling, and that led to worse outcomes. But it's hypothesis generating anyway. But the main thing is that we've trialed interventions to reduce intracranial pressure, and a lot of them have not been, in fact, actually all that beneficial. And the thing is that it's probably because we're using static numbers rather than thinking about the burden of intracranial hypertension, both in terms of it as a time-weighted variable. And this is data from 2015, which simply looked at that, is that we need to think about the time pressure burden of ICP rather than just a single number. Nothing magical happens when you reduce the ICP from 21 to 19. Right, clinically, we'll say, okay, the ICP is below 20. That's amazing. We've done a great job. But in fact, actually, the ICP is still elevated relatively. And if that continues for a long period of time, then there has been a strong association in this sort of data from this data set to suggest that that could be associated with harm. So this is just looking at the insult duration as well as the insult intensity. And you can see, sure, if you have very high ICPs for very short periods of time, you will have likely to have a poor outcome. But even sort of pressures around sort of in the mid-teens, but for longer periods of time, can still be associated with adverse outcomes. So we need to think about the burden of intracranial pressure rather than just a single static number. And it does depend a lot on your autoregulatory status, because your tolerance to high ICP is significantly reduced if you have impaired cerebral autoregulation. So that comes back to thinking about how you can optimize CPP. So we're now thinking about, is it all about intracranial pressure in the intensive care unit? And the answer is clearly it's not. We need to think about other things. And this is where people have started to introduce other sort of multimodal monitoring. And this is where my interest has sort of developed a little bit, particularly around the use of brain tissue oxygen. We know that the brain is dependent on a continuous supply of oxygen. When you think about it from a very basic biological principle, you need to have adequate amounts of oxygen for neurons to survive. Here's a huge amount of cardiac output and blood flow goes to the brain in order to maintain that. And so measuring the amount of oxygen in the brain, making sure that it's adequate, in addition to looking at intracranial pressure and perfusion pressures, makes a whole lot of clinical sense. It's biologically very plausible. And we know that oxygen has to move down a significant cascade all the way from obviously your inspired oxygen through your lungs into your blood, then into your tissue. So there's this diffusion gradient down which oxygen must travel to actually get to the neuron. And we have to remember that the brain, of course, not only is made up of neuronal tissue, but it's also made up of a very intricate network of blood vessels. Every neuron is said to have its own personal capillary. So if the neuron is injured during traumatic brain injury, there's no doubt that the capillary that it's associated with it is also going to be injured. And these are just electron microscopes this is what a normal capillary would look like in terms of having a nice smooth border, and the endothelial lining is nice and smooth and allows for the diffusion of oxygen from the bloodstream and into the tissue, whereas with traumatic brain injury patients, it becomes very damaged in a similar way to neurons. So this idea that you can have a diffusion abnormality where you need to provide more oxygen and more perfusion to allow oxygen to get to the brain, and David Menon's group in Cambridge have demonstrated that this can be reversed with hyperbaric oxygen, for example. But I think this has led to a lot of interest in the role of brain tissue oxygen monitoring in traumatic brain injury and ensuring that there's adequate amounts of oxygen being provided to the brain. And I'll just quickly run through the couple of studies. This was just the BOOST study out of North America. They randomized patients to an ICP only versus a ICP and brain tissue oxygen monitoring group. And what's interesting here, in fact, actually, is that when in the ICP and PBTO2 group, they actually ended up giving a lot less intervention to control intracranial pressure. And this is something which has been quite interesting from a clinical point of view, is that when you monitor the amount of oxygen in the brain and you provide interventions to ensure that that oxygen level is maintained within a normal range, you find that the ICP is much easier to control. And so, that then leads to the use of less interventions for ICP control, some of which can be sort of harmful. So, barbiturate coma or other, high risk interventions you can avoid if you do simple things to make sure that the brain oxygen tension is maintained in a normal range. So they randomized these two groups, and they showed that by using by monitoring the amount of oxygen in the brain and using a clinical sort of protocol at the bedside, they were able to show a significant reduction in the burden of cerebral hypoxia. So those people that had oxygen monitoring in situ had a lot less brain hypoxia, a lot less secondary brain injury. And similarly, they showed this trend or signal towards improved outcomes, with more patients having better functional outcomes, less patients dying if they had brain oxygen monitoring in situ. And that's led them on to the BOOST 3 study, which was just finished enrollment. So that trial is currently, they're going through some data cleaning. We'll hopefully have results from their trial sort of mid next year. They've enrolled 900 and something severe traumatic brain injury patients in North America. That was the odds ratio for improved functional outcome, not statistically significant given it was a small study. The French also undertook a study of PBTO2 monitoring. They randomized 318 patients. I'll just run through this a little bit quickly in the interest of time. They had a strategy which they applied to improve or to optimize brain oxygen tension, very similar to the North American study. And they enrolled very sick patients. So they had some patients they had both pupils were not reacting on admission to the ICU or admission to the hospital, that around about a quarter to a fifth in both sides. So those are quite sick patients. And many of them actually had a motor score, GCS motor score of 1 or 2. So it means that they had fairly significant brain injury. They demonstrated no difference, interestingly enough. So we have a North American study, a small study, which demonstrated significant improvement in cerebral hypoxia and a signal towards improved clinical outcomes. This French trial did not demonstrate any difference, totally neutral study. not any difference in clinical outcomes. And it was twice the size. And it's really interesting to think about why that is, because you can optimize oxygen in the brain through a variety of different mechanisms. You can give more inhaled oxygen, you can improve the blood pressure, you can do a variety of other things. And maybe that the recipe that's employed at the bedside, in fact, actually is important. And perhaps it comes back to this idea that you need to optimize or personalize that intervention for each individual patient. And so what will be important will be to dig into this data and the Boost 3 data. And then, in fact, our own study, which is Bonanza, which will be finishing hopefully next year, to look at what is the actual optimal intervention when it comes to oxygen. So we have a 3-phase study. We're in the 3rd phase. We are currently enrolling patients, and it is using a strategy whereby we randomize patients to either ICP monitoring alone versus PBTO2 and ICP monitoring. And where it's a global trial, we're enrolling patients in 33 centres across the globe, which we're very excited about. So I think what I wanted to do, I'll finish there, and I'm happy to sort of take any questions. But I think that the main sort of take-home messages, I guess, from me would be that there's increased recognition now that I think that we need to tailor therapy to the individual, and the use of sort of broad protocols and broad sort of generic statements about how best to manage patients with traumatic brain injury is flawed. And that's the reason for that is because of the heterogeneity of the disease and of the insult, but also the heterogeneity of the host, and that we have a wide spectrum of people that suffer from TBI, from children all the way through to older people. And so we need to be more mindful of that. And it's one example I've shown you today is that perfusion thresholds need to be modified, they need to be personalized. And currently there are ways to do that using invasive neuromonitoring and some new technology. And really this is around looking at cerebral autoregulation. As I said, it's an intact, highly conserved neurohormonal and neurophysiological mechanism that allows us to select these personalized targets. And there's certainly some encouraging pilot randomized controlled trial data would suggest that it might be beneficial. Static ICP thresholds, the way we use ICP monitoring at the moment, probably is questionable. We need to think more about the burden of intracranial pressure. The current interventions that we've used to try and lower ICP haven't worked. And that might be because, as I've said, because we sort of think that something magically happens when you go from 21 to 19, because you're below 20, which is a typically used threshold, but it doesn't really recognize the burden of intracranial pressure. And then there's a great deal of interest in more personalized care for patients using other multimodal techniques, one of which is brain tissue oxygen, which has received a lot of interest over the last sort of 5 to 10 years. We've seen 2 randomized trials, one of a neutral result, one with sort of an encouraging result, but we await the large randomized trials that'll be completed later this year, and we'll be able to then dig into that in some more detail to work out what are the more optimal ways that we can manage these patients. But that's really all I wanted to say, and I hope that was of interest and useful, and that's my email address, so please reach out if I can help with anything, and thanks very much.
Thank you so much, Andrew. That was just amazing. A really nice snapshot of all the work you're doing in the ICU with the neuromonitoring. I just think many trials have happened, we're still at a stage where we probably don't understand so much as well, which is quite interesting too. The fact that, this is where I think the CBIM with the modifiers makes a huge difference, that there are different factors that are relevant to each patient. I'm going to open for questions from everyone before I ask. I do have a couple of questions, which is quite, but does anybody have any questions? You can raise your hand or you can put it in the chat for Andrew.
Well, I think I said there's clearly a strong case that one size fits all pressure targets don't work for every patient. How far away do you think we realistically are from personalised monitoring being standard practice in Australian ICUs? I don't think we're far away. We have a project here which involves 14 neurotrauma centres across Australia and New Zealand, where we've deployed these laptops. We've asked people to connect them to the patient bedside. At the moment, we're just collecting data and really trying to establish what is baseline practice right now. And in terms of how often do patients have a perfusion target outside that 60 to 70 millimeter mercury recommendation. Because if we find in Australia and New Zealand that in fact actually we use perfusion targets that are actually not reflective of the guidelines, then it'll be we may be doing better than the average beer. I don't think we are. Like I think we will probably be just applying pretty standard interventions. So the technology's there. Really, it's an education and implementation exercise now to be able to get clinicians to buy into this, because it is a black box, and you have to surrender some decision making, which is hard for clinicians. Being a clinician myself, it's very difficult to just do what the laptop tells you to do, because you have been there at the bedside, you've assessed them, you have a sense from a number of years of clinical practice about what works and what doesn't work. And then perhaps this laptop is telling you to do something that would feel quite alien. And that's really, around human behavior is probably the major issue, as opposed to the necessarily the data and the science, because we would have to empower the clinicians to interact with this technology. But I think it's not far away, really. It is very doable with all of the technology that is currently in place in your average intensive care unit today.
That's fantastic. Thank you, Andrew. Any other questions? Heidi?
Hi, thank you. Yeah, really interesting talk. Good to hear about what happens at the coalface. I was really interested in the difference between the capillaries, between the traumatic brain injury people. And I was just wondering if you can explain a little bit more what's going on there, and is it similar to maybe cerebral small vessel disease type phenotype, or yeah?
Well, it's an acute injury. I mean, essentially it's going to be the same force that is applied to the neuron as a consequence of your primary injury will be applied to the capillary. So there's going to be shear injury, there's going to be physical disruption, there's going to be bleeding, then there's going to be swelling, and then there's going to be associated inflammation that happens, and that can disrupt the blood-brain barrier, so that a number of toxins that would not normally enter the brain interstitium then are into the brain interstitium. That can then lead to worsening inflammation, further excitotoxic damage, etc. So it's primarily just a physical injury to the capillary bed.
It's kind of like scarring, is it, that you're
yeah, well, eventually you would see that. Yeah, but I mean, it's really no different to, in some ways, if you sprain your ankle, you roll your ankle, and then you see a whole lot of swelling and bruising, and that happens, and that's because the capillaries are damaged, and then there's a whole lot of efflux of fluid from the vascular space into the tissue outside the blood vessels, because they're not able to retain that water anymore. So it's an inflammatory and direct traumatic injury to the brain, to the small vessels in the brain, which is just as fragile as the neurons. And then they will repair over time, but you will be left. If there's been physical destruction of those capillaries, then it's going to be very hard for them to regrow, and that's where you have areas of gliosis and scarring in the brain where there's just nothing.
Thank you.
Thanks, Heidi. Margot has a question. Do you want to read it out loud, Margot, or would you like me to read it?
Sure thing. I was just curious, your CPP targets, if they're being updated 6 times a day for individual patients, and it's, varied widely across the neuromonitoring period. How do nurses and intensivists actually respond to that target if it keeps moving? I'm just wondering if that's an adherence challenge.
It is a massive adherence challenge. And the thing is that you have to just set a period of time where you're going to go, okay, for the next 6 hours, we're using this target. And then you come back and then you get the next updated bit of data. What I didn't say and go into detail is that to generate this curve, this autoregulatory curve, that needs quite a bit of data monitoring time. And so you need to have a period of probably 6 hours for the algorithm to work to be able to generate the curve. So you set a parameter for 6 hours, and it accumulates data over that 6 hours, and then you get another prompt which says, okay, for the next 6 hours, here is the CPP target. So you couldn't. I mean, doing it any more frequently than that could be very challenging. I mean, the question would be whether or not, with cares, if you're going to do something to the patient, you're going to reposition them, you're going to take them to a CT scan, you're going to perform a procedure like putting in a central line or something else, or take them to surgery for another extracranial injury. whether you should look for a period of stability based on the CPP monitoring, and that's a line of inquiry that we're looking into, because you could foresee that if someone's cerebral autoregulatory status is being disrupted, that they should really have a sort of a stimulus minimization protocol applied, where you just do very little to the patient, so to avoid spikes in intracranial pressure, and you leave them alone until hopefully their cerebral autoregulation returns. So that's something that we're looking into and is an area of interest. But yes, to answer your question, every 6 hours would be the minimum, or maximum, I should say, the maximum frequency.
Thank you, Andrew. Andrew, I have one question, because in a lot of our models where, we've been analysing tract TBI data and a bit of centre TBI data as well on patients with traumatic brain injury, and hypoxia is a big determinant in terms of when looking at trajectories and outcomes. And I'm just wondering, in your data that's coming out or what you presented, is the hypoxia status a big determinant? Because you also show trials where adding oxygen doesn't really make a difference.
Yeah, so it sort of depends a little bit on the timing. There's no doubt that early hypoxia and through observational trials is very clearly associated with worse outcomes. And even hypoxia, I mean, I think there's no doubt that hypoxia is going to be associated with unfavorable outcomes. I don't think that anyone would argue with that.
Yeah.
The question would be whether normoxia is enough, and whether you can just use a measurement of oxygen on your finger, an oxygen saturation probe on your finger, as a surrogate for what's happening in your brain. And that would be the vast majority of patients right now. That's how their cerebral oximetry is measured, is through a finger probe. And you can obviously, you'd say straight away, well, that inherently doesn't make any sense, because your finger is very different to your brain. Your brain's been injured, your finger hasn't. So, the question is, okay, can we just use that probe and aim for normoxia, or do we need to have a probe in the brain and optimize brain oxygen using that number, and that will often lead to extra oxygen being required. I think the indiscriminate use of extra oxygen is not going to be helpful. I think that's probably clear, again, from some observation is the widespread use of hyperoxia in patients where it's not necessary is probably actually associated potentially with harm. But I do think that, the question remains is, if you're monitoring monitoring interstitial brain oxygen tension and it's low, whether you bump that up, whether you try and get that up into the normal range through a variety of interventions, whether that's useful or not, I mean, the jury's out. We shall see.
Yeah. And I guess in this space, is there anything we've learned from the preclinical animal models for hypoxia, ICP, CPP? Like, have they really informed what you do clinically?
I think there's no. Well, I mean, it's really, so the hypothermia story was, it's very interesting. I mean, there's a lot of preclinical and animal model data that support hypothermia, in terms of improving outcomes following traumatic brain injury, or certainly hypoxic brain injury from, say, cardiac arrest. And this is the challenge, I think, with preclinical models for TBI and for cardiac arrest, is that, you apply the standard stimulus, the animal is injured, and then you begin your intervention straight away. But that doesn't mirror clinical practice at the end of the day, right? The patients with TBI typically are going to need to be transported to a referring hospital, and here in Australia that can be hours. And during that period of time, they're going to get exposed to any number of other insults. And so even in the best case scenario, you're probably not going to get patients' temperature down to, to sort of mild hypothermia, 33, 34 degrees or something, for like 4 to 6 hours. And that's just probably not quick enough, and so the challenge, I think, is that there have been a lot of things in the in the preclinical setting, which has shown a lot of promise. And I'm sure there's been lots of small molecules over decades, but they haven't translated into clinical practice, because I think that doesn't account for the heterogeneity in the injury, the clinical environment with which we operate, and knowing when to give the intervention, because as soon as possible is ideal. But unless you're giving it to the paramedic at the roadside, it's going to be very hard to achieve.
Thanks, Andrew. Jamie's got a question. Having regard to the functional outcomes of those who've had decompressive craniectomy, is this strategy used much these days?
No, in certain in the circumstances which would reflect the trial, so where there and this was patients with diffuse swelling, then we don't typically offer decompressive craniectomy. If there is an underlying hematoma or a big blood clot, then sure, we'll evacuate that and often leave the bone off. But decompressive craniectomy is a rescue therapy for raised intracranial pressure in someone with diffuse injury. We don't typically do anymore.
Thank you, Andrew. Look, it's been great hearing from you. Probably one question, just, as an intensivist in general, I'm really interested in how we're sort of leveraging our knowledge from the stroke space. We were in decades where they were only applying therapy and interventions really late after stroke because the brain had to stabilize, and now we're sort of, the earlier the better. And I guess I've spoken to a lot of intensivists around, when is that sort of prime time for applying interventions in the traumatic brain injury? And there's a lot of, I guess, different opinions. You need the brain to stabilize. Probably the ICP has to stabilize before we can even do anything. From your perspective, Andrew, just, what's your take on this? And in a sense, where do you think we are? I don't think we've got too many interventions in the TBI that have really made a significant change to outcomes. I'd really like just to hear your opinion as a last question.
Yeah, no, I mean, you're absolutely right. I mean, there isn't a magic bullet. And I mean, I guess in the more clinical practice that, I've been involved with over time now, the more I realize that that's just unlikely. Like we haven't, when you think about, is there going to be the antibiotics for brain injury? Probably not, right? We just, because it just hasn't happened. And maybe I'm wrong. Maybe we will find a target and a pathway that will be amenable to the administration of a drug that will mean patients have better recovery. But it's such a complex injury. The brain is such a complex organ. I don't know that we're ever going to achieve a single agent that is going to be beneficial. But to answer your question, I think that if we do ever come up with something, it's got to be administered as early as possible. So it's, because that's really to stop the underlying sort of cascade of injury, which can happen. So I would say that as soon as someone's unconscious from their brain injury, they should have it. And then that's why I think that we're, I guess, from a clinical point of view, we've pivoted a little bit to look more at process of care interventions, as I've already mentioned. So looking at things that we do right now that are suboptimal. And so, for example, the perfusion pressure is an example. The brain oxygen tension is an example. Specialized care units as an example. These are ways that I think that we can, even today, we can improve outcomes by looking at those things. While hopefully in, however many years we get this magic bullet. But I think it's kind of unlikely, and we should now focus on doing things on a day-to-day basis in a better way.
Yeah, it's fantastic. I think, Jamie, last question. So just have you been following the studies and trials relating to medications to reduce ICP? So I guess more of a pharmacological angle.
Yeah, so I mean, we've tried a few medications from different investigator groups to reduce ICP, and as I said, I could go. There's a number of things. So hypothermia didn't work. I mean, there's the osmotherapy agents, mannitol and hypertonic saline. They can all reduce ICP, but they don't have influence on clinical outcomes. Barbiturates, so thiopentone, very, very effective at reducing ICP, but no benefit in terms of clinical outcomes. There's agents which look at blocking aquaporins and things like that, and I'm sure we'll get some clinical trial data on them. But I just wonder whether we're barking up the wrong tree, because we've tried lots of different interventions with that surrogate outcome and they haven't worked. So that's why we've been very interested in oxygen, because it's a completely different strategy than just using ICP. But we'll see. We're very, I guess we'll wait for the research.
Okay, so can you comment on pre-hospital procedures and time to care on outcome? time is brain approaches.
Yeah, absolutely. This is complete. This is the narrative that we all have to have in mind from a clinical point of view. Is that we need to maintain, as soon as someone's had a brain injury, we need to be very strictly maintaining the best environment for recovery. They need to be moved as quickly as possible, ideally to a neurotrauma center. I guess the interventions that are undertaken in the pre-hospital environment, not being a pre-hospital clinician myself, so I have to be a little bit careful with that, but they need to be sufficient to maintain adequate sort of physiological variables, but we don't want to delay, I think, transfer to definitive care. So it's that's a bit of work we want to do actually with Queensland Ambulance Service to look into some of that stuff as well, to try and work out what are the optimal pathways for management in the pre-hospital environment. But certainly time is brain.
Thank you so much, Andrew. We really appreciate your insight today and you speaking to us. Really, I think it's been amazing to get this insight on the ICU work that you're doing and how it fits in with the global, I guess, landscape for ICP monitoring and monitoring the brain. I think, yeah, we'd love to see the work that comes out of the group. I am just going to share my slides if I realize how to do that here. Yep, there it is.
I've got to step off. So thank you very much for your time and really appreciate the opportunity to talk to you all.
Thank you so much again. We really appreciate it.
No problem.
Okay, so just for the people who are here, we're going to be having a bit of, I guess, revamping of the QBIC website. So please see that coming up in the future. We've got some, some statements that we're going to be putting up on the website, which we'd like you to feel free to look at, but also provide some feedback if you have, what our real mission is, which is really to coordinate, TBI research across Queensland, across the continuum of care, and outside of Queensland as well, and hence, bringing in speakers like Andrew, who's a global expert in this space. Continuum of care, really starting from ICU onwards till return to community. And so if you have any input that you'd like to give us, we'd like to hear that from you. We're also refreshing our framework. So we've got 4 pillars that we're quite keen on: the precision diagnostics and the basic science in the very early acute phase, but all across as well, the clinical, so targeted interventions and rehabilitation. And this is where we'd like to bring people from, different working groups or different working institutions to put their hand up to sort of, give more insight into the projects that they're doing, what's happening at that community and long-term well-being, and really sort of, the pillar on terms of health systems, policy and practice. Really what's coming up, we've got a couple of workshops that are happening, one in Toowoomba and the other in Cairns. We'll be going there, but we've got some rebranding of the QBIC research framework, the website. We're going to be formalizing a lot more working groups rather than the portfolio, so that we have dedicated expertise in each areas. And then we've got some project opportunities that are coming up, so please keep that in mind. These are the workshops that are taking place coming up, so just stay tuned to our newsletter and whatever Margot puts out there to our membership. And really, if you've got, the next seminar that's coming up is our community seminar. So we've got one which is happening on virtual reality and AI tools to support job interview skills after traumatic brain injury. And then we've got our transdiagnostic framework for understanding psychopathology after TBI. So please stay tuned with that. And then our next community webinar series that will be coming up, and that's not on the 24th of June. Don't know if I've missed anything else, but if you've got people who you think are relevant to QBIC or relevant to knowing what's happening in the brain injury space, please also invite them. And here's the QR code. So yeah, I think, it's free to sign up to QBIC. We'd love our community members to sign up as well so that they can keep up with the latest research, like what you've seen from Andrew. I think he's an expert in his field and really the top state of the art of what they're doing in that sort of acute phase for brain injury care. And if you've got ideas or topics that you'd like us to present as part of these webinars and seminars, but also there's opportunities for workshops, please let us know. So thank you. appreciate your time today, and hopefully we will see you at our next seminar. Have a great day. Okay, bye everyone. I think Jamie, yeah, okay, all good. Thank you, bye.
Thanks, everyone.